All right, y'all. For those of you that follow me on Instagram, I write, I do a lot of things in my stories on like, you're the sRNA or you're the CRNA. And I give you guys scenarios and super fun way to test your knowledge and kind of share what I would do, share the things that I've done, learned from, hear what other people would do. It's super cool. So anyways, I also have them in my Instagram page under my highlight section. You can go back and see old ones I have asked, but they're super fun. So anyways, I say that because I asked a few questions on these diagnoses that I'm going to talk about today. This is going to help you with your care plans. This will also help you with your practice as a CRNA and as in your clinical practice, because I had to review some of these things as well. Because for whatever reason, the 3 diagnoses we're going to talk about today literally just like popped up. I'm like, okay, let me review this. So the ones that we're going to talk about is Scleroderma, Ehlers-Danlos, and Sjogren syndrome. Okay. So anyways, I asked about these in Instagram and it was crickets. I mean, I usually get so many responses on these questions and it was literally like maybe one person, which never happened. You guys are always like, engaging with the posts or the story. So I'm like, okay, I'm going to make a video and review these things. Like I said, again, to help you with care planning and just to help you in the future, should you encounter patients with these diagnoses. Okay. So as always, if you watch any of my teaching, I always start big picture, right? We have to seek to understand. So we're always thinking about things like when it comes to our patients' comorbidities, how is it going to affect our anesthesia care, AKA positioning, drugs, airway, all that things like that. So always big picture, and then you can zoom in once you get an understanding of what is. Okay. So we're going to start with scleroderma. Okay. You might also see it be called systemic sclerosis or CREST syndrome. Okay. So what is it? It's an autoimmune connective tissue disorder, basically too much collagen. These patients have excess collagen deposits or this overproduction of collagen in their body. And what happens is it actually produces fibrosis. It can get fibrosis of their skin, blood vessels, their GI system, their lungs, their heart, their kidneys, anything of that. Okay. Procedures you may commonly see these patients for are EGDs. They might come in for dental treatments, orthopedic procedures, plastic surgery procedures, vascular insufficiency, sympathectomy procedures, amputations, and even lung transplants, which it's crazy. Okay. So starting off in your pre-op assessment, some of the things to be looking for is biggest question is where are your symptoms, right? Where are you experiencing symptoms? Have you been hospitalized recently or at all for any types of complications related to your scleroderma? Okay. Because again, they're going to have probably other comorbidities besides this as well. So that's the basic thing. Where is it at? How does it show up? And again, doing a med list, looking at their medications and stuff like that. These patients should absolutely get medical clearance. And if they see any specialists, depending on what specialist and what's going on, but they absolutely need to have medical clearance before elective surgery. Obviously, if it's emergent, you got to do what you got to do, but just something to look for in the chart. Some of the medications to look for these people, they might be on immunosuppressants. And again, depending on the patient, depending on the situation, depending on the surgery, the surgeon, you'll have to kind of talk with the team to decide, are you going to stop the immunosuppressants or not, pre-op or continuing them on during the perioperative period. So just something to think about. Again, our job is looking at the risk of stopping versus the risk of not stopping them, and then being able to kind of talk and balance that out. Okay. So something to think about if they're on immunosuppressants. And again, getting that medical clearance, talking with the surgeon, and kind of hopefully this is somewhat figured out ahead of time, but something to think about. They could also be on GERD medications for reflux. So some things to be thinking about: do they need Pepcid pre-op? How bad is their reflux? What are they on? Are they on prednisone? Another thing to look for, what dose of prednisone daily? Do they need a stress dose? Because you can get that intraoperative hypotension if we just stop their steroid dose like that. Also, if they have Raynaud's, they might potentially be on nifedipine as well. So those are just some of the meds I just wanted to kind of throw out there that to look for and to be thinking about when you see these patients. Okay, so intra-op. again, and this is also going to affect your pre-op assessment as well, but if the pathophysiology is too much collagen, like I said, causing fibrosis of the organs, we're going to expect their organs then to be in their tissues to be thickened and to be scarred, which is going to cause those particular tissues and organs, which I said, where are they affected at, to not work properly. So let's go from head to toe. Airway could be difficult, right? They can have very tight mouth opening, right? Because of the thickening of that collagen and the skin. So they might not really be able to open their mouth at all, or very slow, very small mouth opening. So looking at that malampati, looking at their mouth opening, even like the mobility of their neck, all of those good things. May need a smaller tube. Are you going to be able to fit a glide scope in there or anything like that? Do we need to do some type of awake intubation? All of those things to be thinking about. Again, we kind of touched on the GERD issue. They also could have decreased gastric motility. So at risk for aspiration, might want to think about adding some Reglan to your anesthesia plan. And again, Pepcid, do you need to RSI them? Kind of depends on the circumstance as well. Pulmonary. Could see some pulmonary, well, I kind of went stomach to lungs, but okay, sorry about that. The airway, stomach, lungs. We'll do pulmonary, then cardiac. But pulmonary hypertension, you could see some restrictive lung disease. They could be susceptible to pneumonias. Have they had pneumonia recently? Recent chest x-ray, potentially pulmonary function tests you're going to want to look for. Listening to their lung sounds. Are they experiencing any shortness of breath? Do they experiencing shortness of breath? What are their meds? Are they able to grocery shop, do chores around the house, walk a block, etc.? All those things. Cardiac, at risk for arrhythmias, at risk for pericardial effusions. All right. So EKG, do they need cardiac clearance? Do they have cardiac issues? They might not, but just things to think about and look for. And do they potentially need an echo, depending on if they have any cardiac problems? A lot of these patients could also have chronic kidney disease, some type of renal disease. So getting your labs, getting that comprehensive metabolic panel, thinking about fluid management, drug clearance, drug excretion through the kidneys, things like that. That's why we got to know our farm inside and out. And then if they do have Raynaud's, again, they might be on that nifedipine, but they're going to be sensitive to the cold, right? So might not be able to use a pulse ox on their hands, their fingers. You might have to use like nose, ear, something like that. Use a bear hugger. If it's a longer case, definitely use a fluid warmer. So quick, just review on Raynaud's really quick is because I've also seen this recently in patients, but it's essentially an exaggerated vasospastic response to cold or to like emotional stress. It can be primary, it can be secondary to, again, this connective tissue disorders like scleroderma, vascular obstructions, could be because of drugs. But it's essentially failure of vasomotor autoregulation. All right, because we need like this balance of vasodilatation and vasoconstriction to maintain our tissue perfusion, which is actually controlled through neurohormonal mediators. So if that system is messed up, right, you get an exaggerated vasospastic response. Okay. And you can lead to, if it's long lasting, you can get critical ischemia and necrosis of those digits as well. So again, be careful with vasoconstrictors, phenylephrine, epi, levofed, dose low and go slow. Dose low, go slow. Okay. Okay. Skin, they can have what's basically called scleroderma, but it's hardening or thickening of the skin. So pre-op, check for any range of motion, any contractures, ask them, do they have difficulty walking around? Where's it at? Because you're definitely going to want to get those, a lot of foam and a lot of padding for positioning in the OR. So be very, very gentle with their skin. IV access, something else to think about if their skin is very hard. IV access could potentially be difficult, may need the ultrasound. And in some people, I've even read that non-invasive blood pressure can be difficult if there's been a lot of dermal thickening, if they have contractures, if there's vasoconstriction, things like that. So you might need to place an A-line depending on how severe their skin thickening is. Regional is okay for these patients as long as you position them correctly. And that's kind of the biggest thing as to why to note where their symptoms are, the system affected. The meds will guide you in that as well. And then side note too, Precedex, ketamine, propofol are great choices of drugs for these patients. Okay, so that is scleroderma in a nutshell. Okay, up next is Ehlers-Danlos. I might not be saying that right, so I apologize. But again, this is another connective tissue disorder. It's actually characterized by collagen mutations, and there's a bunch of different types. There's like 6 different subtypes. There's classic, hypermobility, vascular, kyphoscoliosis, arthrochalesis, and dermatosparaxis. Like, my goodness. But what I want to focus on here is the most common type is hypermobility. So that's the most common one you're going to see. And the scariest one is vascular. So I'll touch on that a little bit as well. So again, it affects, causes, you have collagen mutations. A lot of times it causes hypermobility. It can also increase tissue fragility and permeability of the tissues that are affected. So again, this is the same thing with the other one is where are you mostly affected at? It can also affect cartilaginous tissues. So your trachea, your larynx, great, right? That's our area. We like to keep it clean and classy here, right? And your skin as well. Okay. With the hypermobility one, patients, like I said, that's the most common one, and they can suffer from a lot of chronic pain and a lot of joint dislocations. So again, in pre-op, your medications, letting your medications kind of lead you a little bit, and obviously patient assessment, how they live their daily lives, their meds, their symptoms they experience, that kind. Now, the scariest one, like I said, is a vascular type. This basically has the potential for severe morbidity and mortality in these patients. They are at risk for strokes, vascular rupture, dissection, GI perf, organ rupture, and this has been known to happen when they are 20 years old. And about 80% by age 40 will have one of those complications. So this is can be a very scary and very devastating disease process. Okay. When I was kind of searching through the literature and looking at things, I really couldn't get there's really no clear recommendation for general versus regional. So, again, take it on a case by case basis with everybody. In patients with a lot of like very fragile tissue, obviously doing some type of epidural or spinal, risk of hematoma formation or just bleeding from that, just kind of going in with that. Again, that risk benefit is that's the job. That's why we get paid what we do, risk versus benefit, right? Everything has risk, but what's kind of the balance there? Vascular access can also be challenging for these patients. So just some things overall to think about. And I'm really going to spend the most of this time talking about very briefly about the hypermobility one. Okay. So pre-op, again, I talked about some things to look for. Also look at their mobility, their weaknesses. Are they suffering from any spasms? Okay. All right, let's go top to bottom. Airway. Increase it just like before, risk of difficult intubation, okay, or difficulties. You also want to really look at that cervical spine if they have hypermobility or instability. We do not want to accidentally dislocate them during intubation. So potentially awake, very careful positioning, maybe video scope, gentle intubation, okay? Also is I read that there is a risk of collapse of the trachea with minimal pressure. So no cricoid or very light. I would definitely just probably have another anesthesia provider with you in the room. I mean, I've stopped when I've worked solo or not solo, but I've worked and it's just me and one other person at a place I had a difficult airway. It was a known difficult airway. I was at a surgery center and I stopped the line and I said, you have to come in here and help me. And I talked with the doc. He was fine, but I was like, I got to stop your GI line because I need another hand. So don't be afraid to speak up. I would definitely get another provider. And honestly, again, humility, ask for help, whatever. Another thing, TMJ dysfunction and dislocation risk of their jaw. So being very careful with jaw thrusting and things like that. Okay. So LMAs would actually probably be a great choice for them. If you could avoid intubating, I probably would. But again, just being careful in LMAs. Now, getting to the ventilation portion, they are at risk for pneumothorax, again, especially if they have very bad tissue fragility. You want to be careful with your peak pressures and things like that. An article I read said that pressure control is actually the best for them to really control those airway pressures. They're also at, I guess this kind of actually goes into the ventilation portion as well, or the airway portion as well, as they're at risk of oropharyngeal hematomas. So gentle intubation, gentle ventilation. Okay. Gentle pressure control the pressure, right? Watch for pneumos, watch for those signs of pneumos as well. I'm going to talk about this in another video. I'm going to do a part 2, which I'm going to talk about dysautonomia, because it's another one that I don't think I learned much about in school, and I had to kind of learn outside of school. So I'm going to share all that. I'm working on that now. But they might have this dysautonomia or POTS, postural orthostatic tachycardia syndrome. So the biggest thing there is watching for orthostatic changes and giving them fluid very carefully. Okay. But again, I'm going to do another video on that. So check that out. And I will go into all of those things because there's a lot of things to think about. Okay. And I'm going to go through a scenario that actually happened to me. Even more fun. Neuromuscular blockers, low doses, dose low, give slow. So just kind of, a little bit goes a long way. Okay. And again, just like with scleroderma, high risk for positional injuries. Okay. Stretching pressure can really make those peripheral nerves very vulnerable. Also pre-op them, check for any type of neuropathies. They might have chronic pain. And again, hypermobility. I mean, it'd be really easy to hyperflex or something, hyperextend. I mean, so be careful. So very gentle positioning, even if you can. I mean, sometimes you can't, they have to be asleep, but if you can help them kind of position themselves while they're still awake, that's cool too. Okay. Pad very well. Do not dislocate their joints. Okay. If they suffer from chronic pain, which a lot of them do, pain management. So you want to think multimodal. Again, regional risk versus benefit. You got to be on the aware for hematomas due to vessel fragility. So you got to kind of weigh that risk. I also read something that was super interesting that some people with Ehlers-Danlos may have resistance to local anesthesia, or local anesthesia may have a shorter duration of effect. So it's not going to last as long as it would for other patients. Reasons for this is they're saying that there's swift removal of the anesthetic from the dermis, most likely via vascular uptake and leakage through highly permeable connective tissues. So I thought that was actually interesting. All right. So with these patients, it's very important to have a very thorough pre-op conversation with them, set expectations accordingly for their anesthesia plan. And again, that was kind of more so the hypermobility pieces to look out for. The vascular ones definitely need a complete total workup before I would touch them, cardiac workup, all that good stuff, because they are at risk again for vessels just literally shearing and dissecting and all that good stuff. So gentle with these patients. And last but not least, Sjogren's. So this is not collagen one actually, but it is another autoimmune disease. But it causes basically dysfunction and destruction of exocrine glands. So like your lacrimal glands, your salivary glands. It's also associated but destruction of your exocrine glands, and it's associated with lymphocyte infiltrates and immunological hyperreactivity. Okay. And again, patients who have rheumatoid arthritis, lupus, and multiple sclerosis, actually, this usually accompanies other immune system disorders. So you might see these together in the same bit. So at least you'll kind of know how to manage the Sjogren's piece of it. For this one, again, in your pre-op, just like we said before, baselines, where are they affected? Who are they outside of the OR, right? What are they capable or not capable of doing? How are they feeling? Looking at their med list. Again, the med list is going to guide you as to a lot of the disease processes. They may also be on immunosuppressants as well. So I mean, again, keep them on their therapies perioperatively. I mean, do stop them, again, that medical clearance, talking with the surgeon, those types of things. But normally I would probably say want to continue them. But again, it just completely depends on so many things. They also might have thyroid issues. So looking for them to be on thyroid medications. They may have had lymphoma or have it currently. It's very common in these patients as well. And the inflammation that occurs with this disease Can also cause pneumonia, bronchitis, and other problems in the lungs as well. So doing a thorough pulmonary assessment as well, shortness of breath, looking at their mets, chest x-ray, recent infections, do they have a cough, all that good stuff, right? This disease can also lead to problems with their kidneys. So kidney function, getting that comprehensive metabolic panel. They can also have hepatitis or cirrhosis of the liver. Okay. So this is kind of the things, the sequela of what can happen with this disease process. So just being able to notice and to look for those things and be able to handle those perioperatively. So I'm just going to briefly run down some of the symptoms they have to have. That was kind of the overall kind of picture. And then I'm going to link some of the symptoms to how we manage intra-op. So a lot of times they're going to have very dry mucous membranes, dry eyes, dry mouth from decreased saliva, tear, mucus, and sebum production. So always I would lubricate their eyes, eye lubrication, most definitely for Jen. If it's Mac, I don't know if I would like shove something in their eyes, but maybe if you get them deep enough and do it carefully, but definitely lubricate their eyes before you tape them. Even for intubation, I would put a little lube or some type of lubrication on their lips as well. So be very careful with intubation because their tissue is going to be very friable and dry. Plus they've been NPO. So expect a lot of dryness and lubricate as needed. They could even have vision problems. So sensitivity to light, blurred vision, corneal damage. Again, assess pre-op, know their baselines, and then just be very careful with the eyes and stuff, as I know you always and already are, but just something to think about as well. Definitely use humidified oxygen in PACU and use humidified circuits if you have those readily available. Hopefully you do. Be on the lookout for mucus plugs. They probably need really good suctioning with intubation. May even need to go down that ET tube before you waken up and just check. Or if you have high rising peak pressures, they could have gotten a mucus plug. So humidify that oxygen. Avoid anticholinergics if you can. Obviously, they are already dry. Robenal will further dry them out. Scopolamine will dry them out. Okay. So again, if you only thing you have are neostigmine and glyco to reverse, you got to do what you got to do. But obviously I wouldn't just readily, I'd be careful with giving them anticholinergics. Okay. Cause it's just going to dry them out even more. Oh, like I said before, they also might tend to have like a chronic dry cough. So also assessing that as well, assessing for recent colds, waking up, maybe you want to wake them up deep, some things to think about. They could have a lot of joint pain. They could have swelling. They could be stiff. So assessing that range of motion, being careful with positioning. You guys catching like the theme here? They might even have some peripheral neuropathy. So being able to assess that. Their skin, again, could be very dry, at risk for rashes even. So positioning, tape, dressings, blood pressure cuff, just be careful, be gentle, watch. Maybe if it's a long case, switch the arm, switch to the leg, kind of move it around a little bit if you notice that they're really getting red and irritable skin from it. Okay. Okay. So there you have it, guys. I think we've kind of noticed the theme with these is your pre-op assessment is everything. Your patient's baseline, who they are and how they walk into you is something you want to assess no matter what diagnosis, surgery, or anything they're having, right? Is knowing their baselines, knowing who they are, keeping them within their baselines, keeping them safe, with your positioning, with your medications, with what did they give pre-op? Did we continue this medication? Do I need to maybe dose this intra-op? It's all the same. It really is all the same for every patient, but obviously every diagnosis has little nuances here and there that I just wanted to cover today. So when you see these diagnoses, now you know. And again, we're always looking at, okay, how does it affect my airway? How does it affect my pharm, my monitoring, all of that? But once you dig into the pathophysiology of it, it's going to guide your care plan. And I still do that to this day. All right. You're never going to know everything. So know how to use your resources, know how to critically think, know how to ask for help. That's the job. All right. And I will see you guys in the part 2 video of this where I talk about POTS and dysautonomia. Have a great, awesome day. Happy care planning and happy CRNA schooling.